I'm Jill Angelo, host of the G-Spot. I speak with the most forward-thinking experts in the medical and wellness industries, all in an effort to bring awareness to women's hormonal and vaginal health. When we feel fabulous in our bodies, we are more confident, we have healthier relationships, and we have better sex. Here's to a happy, healthy vagina. I recently connected with Dr. Lora Shahine of Pacific NW Fertility Center. Dr. Shahine joined Pacific NW Fertility after completing her fellowship in reproductive endocrinology and infertility at Stanford University. During her time there, Dr. Shahine served as a clinical instructor in the Department of Obstetrics and Gynecology. She contributed to several research publications, and she trained in one of the few centers for recurrent pregnancy loss in the United States. Besides that, she recently published a book titled Not Broken, An Approachable Guide to Miscarriage and Recurrent Pregnancy Loss. We were eager to talk with Dr. Shahine because pregnancy and fertility challenges are very real for the genneve audience. In fact, many of her patients are in their late 40s and 50s, and the intersection of family planning and menopause can sometimes overlap. I'm happy to present now our conversation with Dr. Shahine about fertility, family planning, and women's midlife health. Thank you, Laura, for joining us.
Thank you for having me.
Absolutely. So before we get into some of the meat of the conversation, why don't you explain, why do people come to you? What do you do for your patients?
Sure. So I am a reproductive endocrinologist, which means that I am a trained OBGYN, or obstetrics and gynecology. And then I went on to do subspecialty training in reproductive endocrinology and infertility. So a lot of that are hormonal conditions, but it's really morphed into truly a fertility specialist. So that's what most patients are seeing me for. They're having difficulty starting their family or completing their family, and they're coming to me to help them plan for their family.
How does a couple or a woman or whomever is coming to you, how do they know when to come see you? Do they know I need to see a fertility doctor, or do they think I need to see an endocrinologist or reproductive endocrinologist? Like, does the common person understand what that is and why they should come see you and when?
Yeah, I think that with the power of social media and people going to Dr. Internet on a regular basis, sometimes people come to the specialist a little bit more quickly than maybe they need to, but in general, we're seeing people that have been trying to conceive for about a year and they haven't conceived yet. Some people have seen their primary care doctor or primary OBGYN or naturopath, some provider, had a little bit of evaluation, maybe some low-tech treatment, but sometimes we see people for lots of reasons.
That's interesting. I think the point I want to dig in a little further on is some people might come to you sooner than they should. What is sooner than they should? What would you recommend them having gone through or do before they come see you?
Yeah, I think that there's a lot of knowledge out there about how fertility declines with age. And I think that it's very good for people to be educated and understand that it is more difficult to conceive after the age of 35 or after the age of 40. But there is a trend towards people, I don't want to say anything negative because it's very good to be proactive and educate yourself, but there are people that come to me who are young and haven't been trying for a full year, and they say, I want to do IVF. And I'm the one who has to sort of step back and say, okay, well, let's look at the big picture. Let's look at this with fresh eyes. And really, truly, if you're, 32 years old and, you're trying to conceive naturally, 80% of people will conceive within the first year of trying. And so it could be that it takes you 10 months to conceive, and certainly we can start an evaluation, but let's not worry too much. Let's just take it one step at a time.
That's great. That's such a pleasant way to address someone's concerns about a very personal thing. When you think about fertility, a common consumer's mind, because of Dr. Internet, I love how you said that, it goes to IVF, which, explain what IVF is, and is that the first thing you think of as a specialist in this field, or how do you, what's kind of the roadmap?
Sure. So IVF stands for in vitro fertilization, And it's a way of conceiving that was invented about 40 years ago. And in its essence, it's basically taking eggs out of the woman's body, having sperm available from the man, helping the eggs and sperm fertilize in the lab, watching the fertilized egg or now embryo grow over a couple of days, and then placing the embryo into the uterus when it's ready. So it's conception and the first few days of embryo development happening outside of the body. In vitro means in the lab.
I see.
And so it's funny, I do see people and talk about and do IVF every day, but the majority of the patients in our clinic are conceiving with low-tech treatment. And so when I'm talking to somebody about the options, like with the very first new patient visit, I sort of say, listen, there's lots of different paths we can go from here. Maybe we just do an evaluation and we make sure there isn't anything wrong and you continue to try naturally. If we find something we need to address, we can focus on that. And then, no matter what, if we're going to do treatment options, we'll talk about them. And it's basically low-tech, which means like maybe pills to help somebody ovulate, intrauterine insemination or turkey baster, getting the sperm where it needs to go, or high-tech, which is IVF. And there's so many bells and whistles with fertility treatment, but I try to break it down to pretty simple, and then we go where we need to go.
As you kind of go through that whole map of options for, a couple or a woman who comes in to see you, are you quickly gauging where she's at in that roadmap, or do you start her at the very low-tech first step? Is it kind of where you start with every patient, or how do you judge where to start that conversation, or where do you start the patient in that stream?
Well, every patient is different, and one of the first questions I ask anyone is, tell me your story and tell me what you expect from this visit. Mm-hmm. And I'll really learn a lot by listening and talking less. And a lot of times patients will tell me where they are. And if people are very different, if someone is young and hasn't really started trying, or maybe the couple, the male has kind of a borderline sperm count, well, maybe the best thing for them is to just try inseminations, and it will really focus on the issue. If someone has found their partner later in life, maybe ready to start their family when they're 40, I talk to them about their family goals. So do you want to have a soccer team, or is one child your family goal? And if they say, well, I've always imagined having 2 or 3 children, and we're starting at age 40, well, let's talk about that. Because if you did conceive even naturally or with an insemination or low-tech turkey baster, that's wonderful that you didn't have to go to IVF first, because it's less complicated and certainly less expensive. But you're pregnant for a year, and then you usually don't really want to try for baby number 2 for a year after that. And so you're trying again when you're 42. And there's a big difference between trying at age 40 and 42. The beauty of doing IVF is it can be a form of fertility preservation, because we have the ability to freeze embryos. Sometimes people are freezing eggs for fertility preservation. Well, if a couple is starting their family later in life, we talk about embryo banking or thinking about family planning. And nothing is a guarantee, but if you have the ability to go through IVF and freeze multiple embryos, you can conceive with one of those embryos now and have the ability to conceive with the frozen embryos in the future.
Great. What are the myths that you have to confront as a physician? How do you address those myths and kind of those expectations?
Sure. So I think one of the biggest myths is if you're rich enough and famous enough, all you have to do is IVF and you'll have a baby magically. Janet Jackson canceling her world tour at age 49 so she could deliver her first baby at age 50. She's not my patient. I have no personal information about her, but it's extremely unlikely that she just conceived easily without a little bit of help. And I think that people in general hold IVF up on a pedestal. It's Western medicine, it's science, it's got so much technology, and there are amazing things that IVF can treat. So the reason it was invented was for blocked fallopian tubes. At its core, it is a way to bypass the fallopian tubes because you're getting the eggs directly from the ovaries and you've got sperm, and instead of the eggs and sperm meeting in the tube, they're doing that in the lab. And instead of the embryo coming down from the fallopian tube and settling into the uterus, we're getting it into the uterus in a different door through the cervix.
Interesting.
So sorry if you had to pull out your anatomy book to think through that. But another wonderful reason to do IVF is if there is a significant male factor or sperm issue, because we have this technology where we can actually help sperm fertilize an egg. You don't really need that much sperm. So people have very low sperm counts who in the 60s would not have been able to conceive a child, now can conceive through this process called ICSI, which is called intracytoplasmic sperm injection. You're literally putting a sperm in an egg. It's amazing. But the final frontier with IVF, what we can't do yet is fix eggs. If you don't have any eggs left or the eggs are very poor quality, we don't have anything that can change that. And so IVF is only as good as the eggs and sperm that we have to work with. And there's a whole industry into, supplements that might help egg quality, or, there are experiments out there that are happening with changing mitochondria, etc. But it's still a big limitation. And so our fix in Western medicine is if we really do not think someone's going to be successful with their own eggs, or they are in menopause. I've had patients who are 16 years old and do not have any eggs left because they've gone through premature menopause. And so for someone who has really poor quality eggs or truly doesn't have any eggs left, they can conceive, they can be a mother, they can have their family. It's just they're using donor eggs. So that's the answer, is using a 25-year-old egg.
Fascinating. So then in the quality, talk to me a little bit about the quality of the egg. What's a good egg and what's a not good egg? Or
a good egg turns into a baby and a bad egg is not a baby. And you know what? That's kind of all we know.
Really?
I mean, I know.
Really?
Of course, there's more technology to that. But an egg is a big single cell. And we kind of look at it under the microscope and we sort of say, I'm going to put a sperm in it and I really hope it works. And of course, there's, great basic science research into certain proteins that are expressed if it's a good egg, or certain, things, amino acids and things that you can measure in the follicular fluid that's surrounding the egg that might predict whether it's good or not. But we're still kind of at the let's try this and hope it turns into a baby.
Wow. That's incredible.
Yeah, it's more technical than that, but I just don't want to overinflate what we can do so far. Yeah.
Do you see the innovation in fertility getting there in terms of, you said kind of the final frontier is the quality of the eggs. Where's some of the exploration happening around there?
Well, the biggest one right now is understanding that the mitochondria in our cells really hold all the energy and sort of help with DNA replication, and the egg has to go through so many changes in order to fertilize and be a good egg that turns into a baby, that there's some research into actually taking mitochondria from a young egg and putting that mitochondria into the older person's eggs, so that older person, their genetics are still getting passed on, but the energy is coming from this young mitochondria. The problem is that the mitochondria also have their own genes, and so it's considered genetic manipulation. So one thing that I think is really important to talk about is why? What is the deal with age, and why don't the eggs work, and what's the difference between female fertility and male fertility, and how come Mick Jagger can have a baby at 72, right?
Yeah, so that's great. I'm so glad you went there.
Yeah, so it's sort of a light bulb moment for me when I figured this out, and I tell patients this every day. So the eggs are the oldest cells in our body. So they are with us when we're born. And when we're born, they're actually frozen in a genetic state. They're in meiosis 1. They're in meiosis 1. And I won't take you back to biology, but that's the genetic state. If you remember cells, splitting and chromosomes coming together, so that's where we're going with this. So they're frozen in this genetic state, and when they ovulate, whether we're 20 or we're 40, that is when the egg has to do all of its genetic work. And by genetic work, I mean it's sitting in a frozen state where it's got 2 copies of each chromosome. And it's when we ovulate that the egg has to get turned back on and get rid of half of its copies of its chromosomes in order to accept the genetics from the sperm. So the sperm comes along and gives its copies, and it's like fitting together like a jigsaw puzzle. And so if the egg makes a mistake, if it hangs on to a chromosome or it gets rid of 2 and it wasn't supposed to get rid of both of them, then that embryo that develops will have an imbalanced set of chromosomes. And the embryo can divide, like cells can divide, and the embryo can implant and things can get started, and it's just not going to be a baby. So it's the most common cause of miscarriage is a chromosome imbalance. It's hard to prove, but we think that eggs that have a significant chromosome imbalance can't fertilize, so maybe that's a fertility issue. And sperm can definitely make mistakes. Sperm are not off the hook. They are half of the genetic equation, but they're made every single day. So guys make millions of sperm every single day, and there's definitely an age factor with sperm, and the counts and the function of the sperm do go down after age 40, 45, 50. We're all arguing about which number. But even when someone's 70 years old, there's a couple of good sperm there, maybe. Mm-hmm. And so some men who are older can conceive. And so if you think about it, the eggs are the oldest cell in our body. Think about all of the things that they might be exposed to over 40 years as well, if you really want to dig into toxins and exposures, and just nothing works the same when we're 40 as it did when we're 20. Yeah.
How about for sperm, how long do they hang out? And then how do they die if they don't get...
They just get reabsorbed.
Okay.
Yeah, and you just make more.
Whereas eggs, they don't get reabsorbed. They flush out during the menstrual cycle, right?
So,
or how does...
Yeah, sure. So every cycle, we have a certain number of eggs that are up for grabs. They're recruitable. And our body makes these hormones called gonadotropins that recruit one of those eggs. And that's the one that ovulates. If we get pregnant, great. If not, all of those eggs that were available, and maybe even more, just die off. So we lose hundreds, maybe thousands, maybe more eggs every cycle, even though we might only be ovulating one. And the frustrating part is, usually when I'm talking to patients about that, they say, oh, but I've been on birth control pills for 10 years, and so I know I'm not ovulating with birth control pills, therefore I must have a ton of reserve, and it just doesn't work that way. So even if you're not ovulating, you're still kind of going through this recruitment and atresia.
And are they kind of being absorbed into the body then, in that case, where you're not actually menstruating?
Right.
If you're on the pill?
They're not coming out of the ovary, they're just kind of going away.
Fascinating. Oh my gosh. So kind of taking a left turn then, and you talked about when the two don't come together precisely, that's a miscarriage. And you recently published a book titled Not Broken, An Approachable Guide to Miscarriage and Recurrent Pregnancy Loss. So obviously people come to you not in always probably a great place, because they're coming to you as an alternative to something they want, which is to be pregnant, and they can't get pregnant, or they have miscarried, or for whatever reasons. How do you approach? That's obviously something that you address every single day. How do you cope with that, or help the women or the couples that come to you work through that? Because it's such a big part of what you do. There's failure in all parts of it.
Yes, my job has very high highs and very low lows, but I am seeing people in very vulnerable states, and there's such a infertility is surrounded with shame and guilt, and miscarriage, as women are so good at making themselves feel guilty. I was too stressed out. I'm working too hard. I had a glass of wine before I knew that I was pregnant. I'm sure that it's my fault. And it's my job to teach them and educate them that it's not their fault, that the most common cause of miscarriage is a genetic issue, a chromosome issue, and it's not something that they can control. And in a way, their body is working because it's figuring it out, and it knows that this is not going to be a healthy pregnancy. Mm-hmm. And of course, there are other reasons that cause miscarriage, and I do look for those, uterine issues or hormonal issues. But no matter what, I want women to still remain hopeful, because even if I didn't run a single test or do a single intervention, most women who are having miscarriages go on to have a baby. Because, they're having so many of those hurdles are met. The egg and sperm are meeting, fertilization is happening, the embryo is implanting, and more than likely it just hasn't been a good embryo yet.
Mm-hmm. Yeah. A good embryo or a good match between the egg and the sperm.
Same thing.
Gotcha.
Yep.
Okay.
Yeah.
So how do you keep women positive through that? You're not only like an MD, but you're kind of like mental health. And in many ways, like what do you do?
Yes. Well, I do a lot of discussion about, I think two things. Number one, knowledge is power. So a lot of my care is educating women and helping them understand how it could be that they haven't conceived of the right embryo yet, and how there are other reasons that they might not be getting pregnant other than it being their fault, and empowering them with knowledge so that they can move forward, and giving them hope back. Because when they come to me, if they've had 3 miscarriages, their only story so far is miscarriage. They're batting 0 for 3, and so they feel like the next time that they get pregnant, they have 100% miscarriage rate. But even if someone's 40 years old and they've had 5 miscarriages, the very next time that they get pregnant, it's a 50% chance that they have a baby.
Wow. And
so it depends on how you say that, because you could say 50% chance of miscarriage, glass is half empty, or 50% chance that you could have a baby. Yeah. And there are things that we can do and help, and I really spend a lot of time talking about self-care. What are you doing to take care of yourself? What do you do in your day to check in with yourself? Mm-hmm. Even if it's just 10 minutes where you write in a journal or meditate, or you take time to go to the gym, or you ask for help from people at work. What are you doing to take care of yourself? Because women are the worst. They take care of everybody else, and they put themselves last. And when you're struggling with infertility or miscarriage, that's when you have the most need.
Yeah. And how does that kind of a psyche then impact a woman's ability to conceive? Because like you said, a miscarriage means your body's working. And I think that's a really positive message that you never hear. But how does the self-care kind of help in that as well?
Sure. Well, the most common question I get is, does stress affect your fertility? And the worst thing I could say is straight up yes, because then people start stressing about stressing, and they stress out about that, and it becomes a spiral. And so, of course, I try to focus on, first of all, people conceive and have babies in the middle of war and famine, which your body is completely stressed out. But also, how can there not be a mind-body connection? And yes, if you are continuously at this stress level, how can that not impact your reproduction? So I'm not necessarily saying it does or it doesn't. And what I try to focus it on is, you can't control what happens to you, but you can control how you deal with it. And so everybody that's coming to see me is at a very vulnerable and difficult point in their life. And so we need to focus on how they can take care of themselves and support and wellness. And you have to find what's right for that patient. That patient has to find what's right for them. whether it's individual counseling, or there's such a great community here in Seattle. There's several free support groups through an organization called resolve.org, where they can go to a website and there's multiple meetings different times of the month throughout the Seattle area. There's a great app that just came out called FertiCalm, and it's free and it's interactive, and it's sort of like, where are you right now? You just had your embryo transfer, you hit a button. How are you feeling? Totally nervous, scared, and it walks you through concrete steps of what you can do to feel better at whatever stage that you're at. Yoga for fertility, there's wonderful options. Books, mindfulness. Meditation is really intimidating for people if they haven't tried it, including me. I really want to try it, but I'm really nervous about it. But I'm really trying mindfulness, because mindfulness is, you can do it very quickly, and it's just about being present in the moment and gratitude and thinking about those things. So there's a lot that people can do.
Yeah, you're just scratching the surface. And I know you've been a real advocate for making the conversation around fertility and infertility and recurring pregnancy loss something that we normalize, that is not so shameful. It's always probably going to be a private thing, but what has been your kind of primary goal, even in publishing your recent book titled Not Broken? Like, what's kind of your goal around opening up or normalizing the conversation?
Yeah, I do. I want to change the conversation around miscarriage from guilt and shame to more knowledge and empowerment and support. Since the beginning of time, reproduction, family building has been the woman's responsibility. And if there's anything wrong with that, it's the woman's fault, right? And so I want to change that and help people understand a little bit more and just be able to have a good resource to educate themselves, be an advocate for their care. There aren't a lot of providers that really focus on miscarriage, and there's not a ton of research into it. There's still so much that we have to learn. And so having patients understand that if you go to 5 different providers, you might get 5 different recommendations, and nobody is right or wrong. We're all in this together, and we're really trying to further information. And the more we talk about it, hopefully the more awareness there is about the issues, maybe the more funding we can have, maybe the more research. So the best guess is that 1 in 4 couples who are trying to conceive have had a miscarriage. I argue it might be more than that, because miscarriage happens before people are showing. We're told not to tell anybody that we're pregnant until after the first trimester, because just in case you have a miscarriage, you can't tell anybody about it because that's just too painful to talk about, right?
Yeah.
And gosh, home pregnancy tests are so sensitive. I think people who are really trying are kind of checking. So I think it's more common than we realize, and there's a lot of work that needs to be done.
Well, gosh, today we've covered kind of the range of everything you deal with as a reproductive endocrinologist and fertility specialist, anywhere from infertility, the innovation that's happening, aging and fertility, and loss. Every one of those is a topic in and of itself. So I think we're going to pick this back up, especially looking at how should a woman think about this as she ages, and her family plan that she wants to have. So are you open to doing that and having another conversation?
Yes, I look forward to it.
Great. Any final remaining comments or words you'd want to leave with our listeners generally around kind of this topic and around just their own optimism if they are in a place of trying to conceive?
Well, I think that I hope people hear this and they remain hopeful. And there's so much fear in our society right now, turning on the news, and a lot of the social media is making people feel very pressured and nervous. You're so it's such a mix between your reproductive years are supposed to be your most productive at work, and I just think that yes, there are options that are out there, and we should talk about everything. But this generation is all here without IVF and without high tech, and so please remain hopeful and just be appreciative of the fact that we have options, and just take it one step at a time.
That's fantastic. That's great. Well, I'm excited because I think this, and even what we're going to talk about next time, is relevant to not only women trying to conceive, working women, but also guidance and advice they can pass on to their daughters. Thank you, Lora, for joining us.
Thank you.
Thanks for listening to the G-Spot. We welcome your feedback at genneve.com. That's GENNEVE.com. You can follow us on Facebook, where you will see more on show notes, and subscribe to us on iTunes, and you'll never miss an episode. The G-Spot is produced by Shannon Perry. Theme music by Smitty. And from all of us at Genneve, think happy, healthy vaginas.